Hello, my name is Dr. Guyami. Today we'll be discussing an approach to bedwetting for NAC OSCE. This video is for educational purposes only. So for the NAC OSCE, when we go to the door, the instruction will be there and we have to read the instruction carefully so that we don't make mistakes when we get inside the room. For instance, if the instruction says, Miriam, a 40-year-old female, presents to the clinic to discuss about her child's bedwetting. In the next 11 minutes, gather pertinent patient's history and address any patient concerns promptly. So we know the agenda, and we know what we want to do. So in this case, we're supposed to spend 11 minutes to gather history, and we now do counseling. We educate the patient. So we have to divide our time. Maybe you can spend roughly 6 or 7 minutes to do history taking, and the remaining maybe 4 minutes to do counseling. But before we enter the room, we need to quickly spend about 2 minutes to formulate our plan. Now that we know we are dealing with a case of bedwetting, an approach that we can take is to write down a list of maybe 5 differential diagnoses that we want to rule in and rule out for this case of bedwetting. Before we go inside the room, we write it down on the paper. So once we do that, the next thing is to knock the door and enter. We give the stickers to the examiner and we use the hand sanitizer. And then we proceed to introduce ourselves. So for instance, we can say, good morning, my name is Dr. John. I'm the physician at the clinic today. It's important to know the name and age of our patient, but in this case, it's bedwetting a child. We want to know the name of the caregiver. We can say, can you tell me your name, please? And then, how may I address you? Nice to meet you. We are dealing with a child here. It is important to know the name of the child and the age. So what is your child's name? And how old is your child? We already did know the chief complaint, which is bedwetting. I understand you are here today to discuss your child's bedwetting. Is that right? And then the patient will respond. So at the beginning, it is important to start by using an open-ended question. We make it broad. Now you tell me about this condition, about this bedwetting. And the caregiver will tell us briefly about the condition. So because this could be a stressful situation for both the parents of the child and even the child. So we need to empathize, we need to show empathy. And there's a mnemonic that we can use to do this in NAC OSCE stations, and that is called 5. F stands for feeling of fears or concerns of the patient we're dealing with. The idea, what do they think could be causing the situation? Function or impact. How does this situation, how does it affect your daily activities? And then expectations. What does the patient expect to gain from the meeting with the doctor? So we don't have to ask all these questions at the beginning. We can just divide everything. Maybe at the beginning, we can ask about feelings and fears. What are the concerns? In the middle, we can say, do you have an idea of what's causing it? So we don't have to ask everything at the beginning. So once we do that, we know, once we have completed the introduction, the greeting, the names and age, then we want to want to know more about um, the condition, we want to analyze it. We want to know about the onset. When did this, for instance, bedwetting could have started since birth. We want to know about the frequency. So example of questions that we can ask: when did this start? Was it sudden or gradual? How often does the child bedwet at night? It could be a daytime bedwetting, or it could be a nighttime bedwetting, or it could even be combination of both. So we want to know about that as well, because that will help us to focus on how to ask our questions, and it will also help us in the management as well. So we want to know if it's continuous or it has been on and off, because secondary enuresis, the child will have like over 6 months of continence, then it will just start after that. Also in NAC OSCE cases or stations, when we're dealing with secretions of fluid, we want to use a mnemonic called COCA-B to analyze the fluid, where C stands for color of the urine. Here in this case of bedwetting, is there any unusual odor associated with it? If we are dealing with secretions, we want to know about the consistency. Is it thin or thick? We want to know about the amount. But in this case of bedwetting, the amount is not necessary. Is there any blood in the urine? That is important as well. It can point us to maybe urinary tract infection. Then we also want to focus on the habits. Maybe the child drinks a lot of water before going to bed, that can contribute to incontinence. Once we know all this, then we want to know more about the history of the child. The pregnancy, we want to know about it. The birth, we want to know about it. The delivery, we want to know. Maybe there are complications. But we cannot jump. We need to introduce a transition statement from here to where we want to go. So we also need to talk about the symptoms associated with the differential diagnosis that we are written down. For instance, let's say we want to focus on 5 differential diagnoses. We want to focus on, or even less, like 4. Here we want to focus on urinary tract infections, one of our differential diagnoses. We want to talk about diabetes, or maybe diabetes insipidus, or back trauma, or seizures, or constipation. There are specific questions that we need to ask to rule in or rule out our differential diagnosis. So for urinary tract infection, we can use a mnemonic called DIFONI, where D stands for dysuria, that is painful urination or even burning with urination. F will stand for fever or frequency, or U for urgency, and N for nocturia. For diabetes mellitus, we know some of the symptoms like excessive urination, thirst, or polyphagia, or there could be family history of diabetes mellitus that we want to consider. We need to ask all these questions so that we can know more about the history. In the family, there could be somebody who is bedwetting. Maybe the mom or even the dad was bedwetting when they were young. We want to know about that. For diabetes insipidus, we want to ask about history of meningitis or brain infection. For back trauma, we want to ask about any back injury. We want to know about seizures, if the patient has experienced seizures in the past. For constipation, we want to know about symptoms that are associated. We want to ask questions such as, does the child have regular bowel bowel movements? Is there a history of difficulty passing stool, or maybe complaints about abdominal pain when passing stools? Has the child experienced any recent changes in diet or fluid intake? Any recent changes in the child's stool consistency? Those are some of the questions that we can ask. So once we are done with the differential diagnosis, now we will be focusing on our top differential diagnosis. Because for post-encounter questions, they can ask us to mention just one differential diagnosis. And this is where we'll have ruled in and ruled out. Then we'll have our top differential diagnosis from here. So to move into history now, like we want to know more about the child's history. So we transition again, because we cannot just jump from there to here. So for instance, you can say, because this is the first time that I'm meeting you, I would like to know more about the history of the child, about the birth, immunizations, nutrition, development, environment, rash, and sleep. So with that, we will cover the binder's mnemonics. So for the binder's mnemonic, B stands for birth. How was the pregnancy, delivery, any complications during delivery? Did you stay longer than usual at the hospital during delivery of the child? Are the immunizations up to date? How about the nutrition? Is the child running, walking, speaking on time? Then we want to know, maybe there's stress at home or at school that is affecting this child, that makes the child to be bedwetting. Or maybe the mom has just given birth to a new child. This could also cause stress in this child that is bedwetting. Or maybe a loved one just passed away in the family. These are all stressful events that could be affecting this child. Another one that we could think about is abuse or neglect. But to ask about this, because this is a sensitive issue, we need to be careful the way we ask this question. We can say, for instance, is there any chance that your child is being mistreated at home? That is the way we can put this question. Then we ask about rash, we ask about sleep. Or these are all open-ended questions that we can ask that will help us to really understand what's going on, and it will help us in the management of this, of any condition that we are facing. And then the next is, once we have gathered the information, the history, we have spent minutes, about 7 minutes, to gather history from the caregiver. Then we will now move into counseling. We counsel, we educate the caregiver. And this is not supposed to be one-way traffic. It has to be two-way traffic. We want to know what the caregiver or the patient in front of us knows about the condition. So for counseling, we start by saying, based on what you have told me, the most likely explanation for your child's condition is a medical condition called bedwetting. We want to know what the patient in front of us or the caregiver knows about the condition. So can you tell me what you know about this condition? Then we just listen, and we let the caregiver or the patient in front of us talk. We listen, and we can also take notes. Then once the patient is done or the caregiver is done, I understand that dealing with your child's condition, bedwetting, can be concerning. Then we now move on to the definition. We define the condition. That is the chief complaint. We define it. Here in this case, we're dealing with bedwetting. So bedwetting, commonly referred to as enuresis, is the involuntary passage of urine and maybe diurnal daytime, nocturnal nighttime, or both after the age of 5 years, despite being considered old enough to have achieved bladder control. This condition is common among children and it is affecting their urinary function, more commonly in boys than girls. And there are two types, primary and secondary. The primary enuresis, the child has never achieved continence. The child has never achieved dryness. And it is typically attributed to maybe developmental delays or neurologic abnormalities in the child. Or we may not even know the cause, which is idiopathic. But for the secondary one, the child has achieved at least 6 months of dryness in the past. And now the child will now start to bedwet again. And this is mostly linked to psychological, emotional, or physiological factors like infections, like diabetes mellitus, or the differential diagnosis that we have discussed, back trauma, seizures, or constipation. And this is the common condition that families face. And it is not a serious medical condition. We also tell the patient, the parents not to be worried because this condition can resolve on its own between the age of 7 and 9 years old. And we do not have to do investigations or any intervention. We can just assure the patient, we can just wait. But there are situations where we can have concerns, like if it is accompanied with maybe dysuria, painful urination, or maybe there's changing color of the urine, or there's an unusual odor, or maybe the stream of the urine it's weak. And then also the secondary or diurnal enuresis as well, can be concerning as well. Or maybe the child is having abnormal gait. Stool incontinence is another one that could be a source of concern. So once we discuss all this with the patient, we now talk about the management. How do we manage it? For the primary enuresis, like we said, it's just time we have to wait. We reassure the patient or the parents of the patient that the condition will resolve on its own between the age of 7 and 9. But if it doesn't resolve, then that is where we can now start to do some investigations. So we tell the patient to avoid punishment and humiliation of the child, restrict fluid after taking supper at night, ensure that the child has access to toilet so that at night when the child wants to pee, the child can just go to the bathroom and pee. The diary and rewards will also be very important. So on days that the child does not bedwet, the parents can keep diary and give rewards. So these are incentives that would make the child to have more dry nights. The alarm therapy is also very, very useful for bedwetting, and is very, very effective as well. So when we're dealing with children that are over 7 years old, this type of age range, they love to go for sleepovers, they love to go for camping. We can introduce like short-term desmopressin, which is a medication that can be taken 1 hour before bedtime. But we need to warn, we need to let the parents know that one of the side effects of the medication is called hyponatremia. That is low sodium level in the blood. And the effects of this could be headaches, seizures, confusion, and so on. For the secondary enuresis, because we already know some of the causes of secondary enuresis, like we discussed, like diabetes mellitus, like urinary tract infection, like meningitis, we can treat all these conditions. We can manage them. Then we can also introduce pharmacotherapy like desmopressin, imipramine, and oxybutynin. So once we have um, counseled our patients or the caregiver, then we want to know what the if the patient or the caregiver really understands what we have discussed, then we ask the caregiver to tell us what he or she understands. And then we just listen to the caregiver. And then we also ask the caregiver to ask us questions. Are there any concerns that he or she wants us to address before leaving the clinic? So once we are done with that, we also provide pamphlets and brochures that the caregiver or the patient in front of us can read at home to get more knowledge about the condition. Then it is also very important to schedule a follow-up. So we tell the caregiver to come back to the clinic so that we can see the progress of the plan that we have drawn and we are executing. Then the last thing is to thank the patient. This is very, very important. We thank our patient before the patient leaves the room. And that is the end of this presentation. I hope this would be beneficial to somebody. Thank you so much. Bye.